We'll talk about echo assessment to guide fluid therapy, and I guess that's a little different from the idea of fluid responsiveness. But so I guess I'm going to try and give an idea of what the evidence suggests and what we expect to hear in an exam, and that is slightly different, I guess, from what I do in my clinical practice. So anyway, I'll show you what I can. We'll talk a little bit about static parameters and dynamic parameters. And in, for example, a written exam, if they were to ask you this for the DDU, they very much expect you to split them out like that, I suggest. In real life, I think they get a little bit more melded together. Very importantly, though, we must know about the limitations of what we're doing with static and dynamic echo parameters. And I'll try and tell you a few pearls and pitfalls and sort of false positives along the way. As we start, please can I just make it clear what I do, and that's not perfect, but I think it's just what I do. Fluid responsiveness, of course, does not mean that everyone needs fluid. There has to be a clinical context to what we're doing. So echo does not replace anything that we are doing. We still need to assess both clinical and biochemical features, and I try and add in echo or lung ultrasound to try and help with that. More often than not, I find that echo and lung ultrasound are helping tell me when not to give fluids, not when to give fluids. But there is some evidence, particularly dynamic parameters, that echo can help predict fluid responsiveness. In my experience, I think echo is probably more useful when to stop giving fluids, as I said. There are lots of limitations to doing these assessment tools. None of them are perfect, including echo and clinical exam, as of course you know. And we'll try and go through a few of those as we talk through each parameter. I'm always reminded when I'm giving this talk of John Myberg giving the plenary lecture at the ICU annual scientific meeting, where he talked about the problems with, he highlighted an issue of seeing people doing echo when a patient is clearly clinically hypovolemic. So, for example, in a trauma or a patient who's bleeding after cardiac surgery, and people would be doing echoes. And he said he found that quite, counterintuitive, because what we should be doing is sort of mobilizing the troops to give, aggressive fluid therapy and just trying to replace the fluid that is being lost. And I guess that kind of struck a bell with me, and I know what he means. We're clinicians first. You don't go for the echo immediately when you're assessing a patient to see if they need fluid or not. If it's clear that they do, just give fluid. You don't need a detailed echo exam to tell you that. So just make sure that echo doesn't delay any medical therapy. And then my final thought as I start this is I think dynamic parameters are probably better than static parameters. Okay, so when we're talking about giving fluid, the concept that we think about is this fluid responsiveness. So that means that when we give fluid, we will increase someone's stroke volume. If you have a place on the Starling curve sort of marked with this area A there, the capital A, if you are preload responsive, or if you are on that ascending portion of the Frank-Starling curve, when we give you a fluid challenge, and be that they talk about an expiratory occlusion tests on a ventilator or a passive leg raising test, or given a fluid challenge, you will move that preload up the curve, and that will therefore improve your stroke volume. And that's what we're trying to do, as opposed to if you're on the flat portion of the Starling curve, or if you have a poor ventricle function or poor preload reserve, as some people call it, where you will give fluid and you will not get much of a change in stroke volume for a significant change in preload. Now, of course, means that you are at risk of becoming fluid overload. So that's the theory. So let's talk about our static parameters. So what I take to mean by static parameters is something that's just at one point in time. So these are all assessments that we can do at one point in time and try and make an assessment of whether someone or not would be fluid responsive. As in, if I make this assessment in time, I then give some fluid bolus to this patient, would they be responsive, yes or no? I find some of this a little, esoteric or just simple, to be honest, because we very, very rarely do something in clinical practice where we just do something, where we make an assessment in time, we do something, and then we don't assess the response. The times that we do that, I guess, are as if we are, maybe being a little lazy at times. I certainly know that I've been guilty of this with echo. Echo takes time, and sometimes when we're doing something and we don't go back and check what we've done, that can be, we can miss things. So I guess what we should be doing with static parameters is assessing it in time, and then maybe it can become more useful. But as we look at the literature, this is just what static parameters talk about, are just assessing these at one point in time. So start with the IVC. Got a bit of a love-hate relationship with the IVC. I think it's, it can be relatively useless sometimes in assessing fluid responsiveness, unless it looks like this. What I think the IVC is good at is assessing right atrial pressure. It's good at assessing right atrial pressure. When it looks like this, we can say that the right atrial pressure is less than 5. Okay, that's what it's pretty good at. I think if you've got someone who you think is clinically fluid responsive, so, they've got raised lactates, they're tachycardic, they're hypotensive, they've got pretty good signs of septic shock or something, they've got poor capillary refill, low urine output, AKI, whatever, that is someone who is probably going to be, assessed as clinically as needing fluid. If I see an IVC that looks like that, it can be useful because it backs up my clinical judgment. I just find very rarely do we see something like this and we've totally missed someone being fluid responsive, but it's important to know. But it's good for showing you that the right atrial pressure is less than 5, as opposed to this patient who's got a big, fat, plethoric IVC that doesn't collapse with respiration, be that mechanical ventilation, expiration, or inspiration during spontaneous breathing. This patient is going to have a right atrial pressure that will be high. And the maximum that we can estimate with this is we say that it's somewhere between 10 and 15. Okay, we don't know if right atrial pressures are greater than that with assessing the IVC alone, unless we're going to use maybe some form of Doppler. But, you get an idea that you've got a big, fat, plethoric IVC. Someone who is fluid overloaded may have an IVC that looks like this. But it's also going to be pretty dodgy if you've got significant tricuspid regurg, you're on a lot of PEEP, you've got right ventricle failure, any of those kind of assessments. So there are lots of caveats for a patient who's got raised right atrial pressure for having hypervolemia, but I think we can say that if you're spontaneously breathing, you've got an IVC that's small and collapsing, you're going to have a low right atrial pressure. If you think they're hypovolemic, that may support your assessment. If you're fully mechanically ventilated, same thing happens. According to the literature, they talk about less than 20 or, so greater than 20 or greater than 75 if you're spontaneously breathing with IVC assessment. Sure, that sort of thing, whatever. But, I think if it's small and collapsing, the IVC means you've got a slow right atrial pressure, mix that with clinical signs of hypovolemia, you're going to be fluid responsive. If it's bigger than that, you've got lots of caveats to that. You've got a raised right atrial pressure. And I think we've got pretty good evidence that a CVP is pretty useless as a static parameter in assessing fluid responsiveness. And the same then goes for the IVC. Please interrupt me if anyone has other views. I recognize the considerable expertise of the people who are on this, so please speak up if you disagree with any of this. So the caveats that we've got to know for the IVC is the fact that you're trying to measure. I've got a circle here that I've drawn for this cartoon. The IVC is probably more of a ellipsoid or a squashed balloon shape. You've got to try and measure that, and you've got to watch for translational error. So as you breathe, you've got to make sure that you're measuring in the same place, which is, of course, quite tricky. So this love-hate relationship I got for it is I've shown you the reasons where it might be good, and this is the reasons why I feel it's bad, because it is next to impossible to try and measure the IVC perfectly in the same place during a respiratory cycle. It moves all over the shop. The second thing is this one. What do you think about this? I've said that I think we've got a plethoric IVC as a sign of raised right atrial pressure. Can anyone tell me what we're imaging here? Michael, I can't see anyone, so I'm going to have to choose you, Michael.
Descending aorta.
Great. You've got to see your right atrial junction, right? So you've got to make sure you're imaging the right thing. Common error to make sure that you're not missing it and imaging the aorta because you're looking to the patient's left. Thanks, Michael. Okay, so that's the IVC. Next we talk about is the left ventricle size. So this I find a little bit more useful. I'm going to show this example of an 84-year-old woman with a non-STEMI. She's hypotensive and cool peripherally. So I think I've got clinical signs of hypovolemia, and I've got good signs here of someone who's got a small ventricle with a hyperdynamic ventricle function. So that's where that kissing ventricle sign comes through together. We've got the IVC that I showed you a minute ago, shows me that I've got a low right atrial pressure. These things, as a point in time with that clinical picture, would suggest that this patient is hypotensive. Again, I think we've got to be mindful of the fact that this doesn't catch us out very often, but sometimes it does. And so I find this a little bit more useful than looking at the IVC alone. And that's what I mean when I was talking earlier about, we never take one of these things in isolation, we kind of use them all together. And this would be the kind of patient where we would be giving fluid, right? So it's a static parameter. It's, we teach it in basic courses all the time of someone who's got clinical signs of hypovolemia, all right? And this is classic in a patient with septic shock. What I mix in with that all the time is this parameter here. So this is, if we were to put our continuous wave Doppler or use our color wave Doppler to try and have a look at that kissing ventricle sign, we put the continuous wave Doppler down through the apical 5-chamber view through the aortic valve, and potentially we can start looking for late peaking jets. All right, so these late peaking jets, I don't know if you can see my mouse, but the late peaking jets, so what's been marked here by the number 1 is during the end of systole. So you're getting the peak happening towards the end of systole. So again, systole is from the beginning of the QRS to the end of the T wave. If you've got late peaking jets, that's a sign of some form of obstruction happening somewhere down that line. Continuous wave Doppler has the benefit of telling us high velocity speed. So here I've got speeds going up to 4 meters a second, but it can't tell you where the obstruction is. But I'll use it to try and find out if there's any sign of any late peaking jet. And for the really observant of you amongst this, it's going to see that we've probably got this jet behind. There's probably got a bit of a parabolic phase starting relatively early in systole, which might be MR. We've then got a middle late peaking jet with a peak velocity up to 3. And I think you can probably see on the second one a bit better. There's a third late peaking jet that's at the top. That's probably got a peak velocity of around about 1.5 meters a second. So what we can use then is pulse wave Doppler at different places along that continuous wave Doppler line to try and determine where the sites of obstruction are. As you can see here, the maximum site of obstruction is probably at the LVOT area. It's got aliasing happening because the peak goes off the end of the pulse wave Doppler trace. But we're not looking to find out the exact peak velocity. What we're looking to try and find is the site of obstruction. And as we call it driving the pulse wave Doppler box backwards, we start going and seeing that this late peaking jet is not just present at the LVOT, but present both at the mid-ventricle and at the apex. And this late peaking jet is what happens on flow, on Doppler, when you get the kissing ventricle sign. And the analogy I'd use is you going to your garden hose, turning it on and letting it flow out, just holding it in front of you, and it would maybe go 1 meter. As you were to squeeze that hose closer and closer and closer, the jet would go further and further and further until you completely obstructed the hose, and then it would stop. So the hose would go faster and faster and faster and then abruptly stop. And that's what we see on each of these traces. But what the pulse wave Doppler is then showing us is those 3 waves that we saw on the other one came from probably the mitral regurg, from your LVOT, and from higher up in your ventricle. And this higher up in the ventricle sign, here, so just showing you in a bit more details. So there's continuous wave Doppler again. And there you would just watch that pulse wave Doppler box in the middle of the LVOT there on the sort of still 2-chamber view, still beam mode view. And as I drive it back, you can see that it gets smaller and smaller, but it's still present. And this reminds me of one of my favorite papers done by Michel Slama and his group, where they looked at patients with septic shock, and they were looking for interventricular obstruction, IVO, and they were considering that to be a marker of potentially hypovolemia or excess catecholamine use. But the idea being that if you had this interventricular gradient, it's sort of linking it in with the volume status. And if you saw that it was associated with far worse outcomes, which I find really interesting. So they had the mortality rate at 28 days was higher in those patients who had the interventricular obstruction versus those without. And that was on echoes, on echoes when they had septic shock. So I think it's really interesting, again, suggesting that if you've got significant hypovolemia and you're not monitoring it and you're not going to treat it properly, that is going to be associated with worse outcomes. Okay, so their conclusion was left interventricular obstruction is a frequent event in septic shock patients with an important correlation with fluid responsiveness. Mortality rate was found to be higher in these patients in comparison with those without obstruction. Okay. So at the other end of the extreme, when we're not going to give fluids. So static parameters that I could look at here would be left ventricle size. If you've got a big left ventricle, which is poorly functioning, that can be associated with raised left ventricle end diastolic pressure. That's going to give you a big left atrium. You can see that intraatrial septum pushed over to the right. That is going to suggest that we are right on that flat portion of the Frank-Starling curve, where if we give fluids, we're going to increase up our left atrial pressure, increase in the left ventricle end diastolic pressure, and that's going to push our patient into pulmonary edema. I think it's really important that if we're looking at left atrial pressure, we don't look at one parameter alone. I think the intraatrial septum is a really great marker, but we can also have a look at other markers, and that's using Doppler. And such as in this lady who was 45-year-old PJP pneumonia, hypotensive septic shock with a rising lactate, who's ventilated. Having a look at her heart tells us we've got a ventricular function that is not working well at all. So she's got moderate diastolic dysfunction, big left atrium. She's got significant tricuspid regurg. And that's probably because her right ventricle might not be working brilliantly either, but she's got some significant pulmonary hypertension. You've got a TRV max of 3.3. We've got some MR that's complicating the picture. We've got a left atrium that is dilated, so it's above that 34 mils per meter squared or 36 mils per meter squared. Difficult to see that intraatrial septum. And then the echo markers of diastolic function so that we can estimate what our left atrial pressure is. I think in the critically ill, as we're going to talk about lots in the future, the left atrial pressure, trying to talk about diastolic dysfunction is sometimes controversial, but what we can try and say with a yes or no answer is, do you think there's signs of raised left atrial pressure? And clearly in this patient there is, when we've got these E to A ratios that are greater than 3. See that in the top left image on that mitral inflow view. We've got tissue Doppler on the bottom images there where the medial annulus is less than 0.08, so less than 8 centimeters per second, and the lateral less than 10. So here we've got 4 and 6. And that would clearly tell you that you've got a raised E to E prime ratio. So the E velocity there is, call it 1, and the average is 0.5. So we've got an E to E prime of 20 there, and anything greater than 14 is raised. And then the last one is that top right image with the pulmonary vein flow, and you've got systolic blunting, again, suggestive of raised left atrial pressure. If we've got that static parameter of those static parameters there of that raised left atrial pressure, we've got to be having a pretty bloody good reason to want to give this patient fluids, because I would have thought if you give too much fluid to this patient, even 100 mils too much, it's just going to end up in their lungs. So these would be the patients that we should continue with catecholamines and just push those and try and exclude other causes, but it's not going to be fluid responsiveness. Okay, so there's still echo parameters, but I think the integration with the clinical signs and symptoms and echo can be quite a powerful mixture. So those are the static parameters. Are there any questions so far before I move on to talk about the dynamic ones? Okay, so far? Okay. So dynamic parameters. So I think you can kind of split these into 2 main groups. The first one is ones where we're looking at respiratory variation. So we're looking at things over a 2-point period of time, but it's dynamic because it's because it's done over a respiratory cycle. I find that there are a lot of caveats with this. This is not something I use a lot because there's a very select patient group that you can do these in. The other group that I should do more than I do, because it takes a bit of time, but it's worth having a look at, and it's certainly got the best evidence, is a passive leg raising maneuver. And that's much more versatile, again, not without its caveats. And I'll go through some of the limitations of both of these. Okay, so the respiratory variation is particularly looked at, except for the IVC, in patients who are mechanically ventilated. So I'm going to start off talking about that first. Heart-lung interactions is probably a part of another talk coming in, but as you know, if when we're getting insufflation, we are forcing air into the lungs, and during expiration, you're going to reduce that, and that's going to cause that maybe then with full mechanical ventilation, we will cause reductions in our LV preload if you are preload responsive. Okay. So if you're going to make any kind of assessment, though, for a patient who's being fully mechanically ventilated, that requires them to be in sinus rhythm. They can't be horribly tachycardic, and they can't be too bradycardic. You need them fully mechanically ventilated with a decent tidal volume. So that's not 6 mils to 8 mils per kilo ideal body weight. You need to be higher than that. And in the literature, sometimes they talk about 10 mils per kilogram ideal body weight, and you do that transiently. You can't do it if they're bradycardic or bradypneic or tachypneic. And we've got to watch out for right-sided heart failure, because that can give you false positives. So the actual group that you can do this in can be quite limited, shall we say. But the evidence is the best for this as being a marker of being fluid responsive. As in, if you think that patient needs fluid and you give it to them, you increase up their stroke volume. So examples would be the measurements that you can make. You can look at the peak LVOT velocity. And here you can see that in responders, and I'm so sorry, I should tell you where I've taken this from. I've taken this from the Oxford textbook of critical care echocardiography done by Prof. McLean, Stephen Huang, and Andrew Hilton. So this would be an example here on the left of someone who might be a responder, where you've got a greater than 12% change in your peak velocity LVOT Vmax. All right. They're measuring this with transesophageal echo. You can do it with transthoracic as well. And then on the flip side, on the other one you see on the right, that's someone, a non-responder, where you have less than a 12% variation in their velocity. The kicker with this, though, is you've got to make sure that you've got an absolutely accurate measure up the LVOT, and you're not getting changes happening with respiration. And as anyone, I think, who's doing Doppler can tell you, that can sometimes be pretty challenging in our patients, okay? It's probably a bit easier with toe, but it's certainly a bit harder with transthoracic echo because you're getting a lot of chest movement, right? The second thing that we can look at with respiration would be your SVC collapsibility. It was particularly looked at a long time ago. Now it's 20 years ago by Antoine Vien-Baron in his paper that we all know about, where he shows this incredible sensitivity and specificity if we look at the cutoff of 36% being able to produce the 36% collapsibility. So here you can see that responder on the left, SVC assessment. So that's done, you have to do a toe, obviously. Again, fully sedated, mechanically ventilated, 10 mils per kilogram ideal body weight, sinus rhythm. You're looking at about 190 to 110 degrees over to the patient's right in a high esophageal view. You start with your bicaval view, and then you just pull up a little bit. And you do that till you see your pulmonary artery. You can't get this in every single patient, but it's something that you can get in most. Once you've got that pulmonary artery, which is that circle that you can see at the top of, you can't see my marker, can you? Anyway, that where it's just.
You can see your mouse.
Oh, you can. I can't see it. No, I can't see where I'm pointing, I'm afraid. So that little circle under the R of the second R of responder, that little circle is your pulmonary artery. You use that as your baseline sort of point, and then you can put your M mode down through the SVC, which is just underneath it, and you can see like the long worm underneath it. If you have the collapsibility of 36%, that's suggestive of being fluid responsive. And they estimated that as, I think, being an increase in, I think it was 10% increase in your stroke volume. Non-responders, big fat plethoric SVC. Okay. I think when Antoine was doing this originally, he didn't want to have to put in this receiver operating curve because he said he felt it was, didn't quite match in with clinical assessment, which I agree with. But it's kind of stuck, and it's now been looked at, and it's probably one of the best ways of having a look at being fluid responsive or not in a patient. The last one is looking at the IVC collapsibility. You can do this with a distensibility index in spontaneously breathing patients. I think for all the caveats I've just said, I think it's really next to useless because of the movement that you get with the IVC. I think it's pretty hard to look at the IVC with toes, so you're linked with transthoracic. I think you get a lot of movement going on. I think if you've got images like you can see on the right, it's a bit hard to make accurate measurements. I don't think the IVC is great for these. But, in an exam, you've obviously pretty easily got to mention it. And it's got better evidence than using IVC as a static parameter. But this is a collection of, from this Advanced Critical Care Echo textbook, and Philippe Vignon's chapter, where he can show you sort of summarizes quite nicely the evidence with the thresholds and the sensitivity, specificity, and positive and negative predictive values. And the best one that you can see from the literature is the change in the SVC diameter. And it's probably, I would argue, the most reliable, maybe, because you don't have the caveats of imaging of transthoracic from the LVOT and the IVC, maybe. But they've all got caveats and they ain't perfect. Okay. Now, sometimes the patients don't read the textbooks, right? So let's have a look at this, and maybe I could ask Rishi, maybe you'd have a look at this for me. So 68-year-old lady with ARDS who's mechanically ventilated. Firstly, what do you think of the right-sided function and size?
So the right side looks at least moderate to severely dilated.
Yep.
And the longitudinal function appears preserved, but the lateral contractility appears reduced.
Excellent. So what would you say the function is? Mild, moderate, or severely impaired?
So I would say mildly impaired at this stage, because this predominant function is by the longitudinal function, but it's moderately dilated.
Yeah, interesting. So I would probably call this moderate, if not severely impaired, just because of the only part that's really moving is that basal area. I think, as you said, we've lost that contraction. The fractional area change, you can imagine, would be grossly impaired. Okay. And I think you're going to mix that with, obviously with clinical findings. But yeah, I think it would be at least moderately impaired. I think I'd have said that. But this is what the LVOT trace looks like. So here we're looking at our LVOT. We just talked, you can either measure your LVOT or you can the VTI, or you can measure the Vmax. Either way that you do it, you can see that we've got significant variation there during the respiratory cycle. So based on what I've just said, that means that this patient would be fluid responsive, right?
Yes. There was a caveat you mentioned that the RV function should be normal.
Yeah.
So why we have to, because we have to make sure that whether the patient may be fluid responsive, but whether he'll be fluid tolerant will be the main question.
Yeah, nice. So it's a great point. So just to make sure I understand, you're saying that therefore this patient might be fluid responsive based on the LVOT change here, the LVOT trace change, but the tolerance would be impaired because of the right ventricle failure.
Yes.
What you're saying, nice. Okay. So what you got to be careful of is that this patient is probably, as you said, not going to be tolerant because of the right ventricle dilation. But what we're seeing here is what happens when you get ventricular interdependence. So as that patient, as you get insufflation and you get dilation and you get that increase in the RV afterload, you'd cause that interventricular septum to be pushed over to the left. And as you push that interventricular septum over to the left, that is what can give you the respiratory variation changes you're seeing because you impair the LV filling. So you can get a false positive with right ventricle dysfunction due to interventricular dependence. Okay, so does that make sense?
Yeah.
Cool. Does everyone else understand that? So I think it's an important point to have a look at these ideas of false positives. Okay, and that particularly comes with right ventricle dysfunction and dilation. Right. So there are lots of limitations, I think, as I've talked about with those dynamic parameters. So accurate imaging, especially with that respiratory variation, particularly transthoracic, I should say. You don't want to have arrhythmias. You need 10 mils per kilogram, ideal body weight, tidal volumes just transiently, and the rest rate and the heart rate to not be too high and not be too low. I find there are lots of confounders in there, particularly right ventricle dysfunction, abdominal hypertension, open chests, you name it. And that's why it's not perfect, unfortunately. So, all right, next one to think about is our passive leg raising maneuver. So I am guilty of not doing this enough in my practice, but it has the best evidence for use. All right, so the theory is that you've got about 300 to 500 mils of fluid from your belly button down. And if you have a patient who's sitting up at a 45-degree angle and you lay the back of the bed down and lift their legs up to a 45-degree angle, you can deliver a transient 300 to 500 mil fluid bolus, and you can then assess some of the things that we were talking about before. You can assess your LVOT Vmax, you can assess your VTI, you can assess your FVC collapsibility, and I don't think probably the IVC would be the best, but you know, I haven't actually seen that, but maybe you could do that too. And then you look at it before and after. It's a little more versatile than looking at those parameters just with the respiratory cycle. So there's evidence to show that it can be used in patients who are spontaneously breathing to predict fluid responsiveness. It can be used in patients who are having pressure support breaths, but you just got to try and make sure that you're comparing like with like when you're doing each maneuver, when you're head up and when you're head flat. You can do it with arrhythmias. Again, just trying to choose the same RR cycle length. And you can do it with patients with low tidal volumes and low compliance. So there's a huge amount of research that came out looking at this in particularly from Europe. The limitations I'd say is that I don't. When I started trying to use this, when I started trying to use this, I do find that it's not straightforward from an imaging point of view. I think the time and the manpower, it's got to be a two-person technique. You can't do it if you've got any kind of raised intra-abdominal pressures. You can't do it if obviously you've got intracranial pressures that are high, and you can't do it if you've only got one, if you've got limb amputations or you've got pelvic or limb fractures. So one of the problems why I find it tricky is that I think the beds are made differently in Australia compared to Europe sometimes. I don't know what it's like in the rest of the world, but we can put a bed up to sort of 30 to 45 degrees. So we can put a bed up to about 30 degrees, but it's sometimes a bit harder to put it higher than that on our beds, particularly the old ones. And the next part is accurately measuring the LVOT, VTI. I'll just show you what our beds look like when we move them. So we can't put the legs up to a 45 degree. We can have beds that do this where they go to 30. And then when we lift them up, they can only about go to somewhere like this, where you have to lay the bed down. You have to keep the bed in a sort of 30-degree head up position. And then you have to, if you want to do this, you then have to tilt the whole bed. Don't put the back down and then the feet up, because the feet won't go up like that. You have to do the whole bed sort of moves. You've got to sort of, tilt the bed on the fulcrum. So it's a little tricky. And my tip and trick, if you're going to try and do this, is you keep your hand in the same position. Don't move your hand and then press all the buttons and then move your hand back, because you can lose the accuracy. Because you're looking at, they talk about a change of like 12%, which I find crazy. I mean, I think if any of you are measuring LVOT VTIs, you imagine, like with this guy here when I was doing it, he's got an LVOT VTI of 13.3, and then I did the passive leg raising maneuver, and then I measured it at being 14. So it's not a 7%. It's like a 7% change. But just trying to look at a 12% change, you've got to make sure you're measuring it really accurately, and you've got exactly the same angle, and you've got to make sure you're doing the very similar kind of tracing. And you sure as hell don't trace this when you've got 14 or 15 cardiac cycles there, because you could then be off a little bit with your tracing, and you could get, again, false positives or false negatives. So you've got to make sure, if you're going to do this, your accuracy is right. You do it in a consistent manner, and your Doppler angle is the same. So, yeah, so this is the evidence that they talk about. You know, threshold changes there of anywhere from 10 to 15%. You know, this requires accurate imaging, right? Accurate Doppler angles. And even then with that, I think we've got unbelievable sensitivity and specificity that's been pulled out from some of this, to be honest. But I'll, you know, I don't mean to bag it out too much, but I just find it's not quite as easy as all of this puts through. But you need to know about it because this is where the best evidence comes from, or the most evidence comes from for fluid responsiveness. If you're doing the EDEC, they absolutely expect you to know this because all the authors are on the on the guys writing the papers. One of the more recent, most robust papers done here, which was done by Philippe Vignon and his group, again out of France. So you'll recognize a lot of the names in that, including, you know, Philippe, Michel, Antoine, you know, the big players there. So they did a multi-center study across 540 patients, and I'd argue this has got to be one of the largest echo studies ever done. And they tried to assess the accuracy of these dynamic parameters to predict fluid responsiveness. And they used a passive leg raising maneuver as their, and they used the passive leg maneuver to then try and decide whether they were fluid responsiveness, giving you a greater than 10% increase. So again, all of that not without some of its caveats. And they found that the SVC had the best predictive ability, but it was far less than was originally reported back in 2004 by Antoine when he was doing his paper. So there you can see the area under the curve is about 0.7, and it's you know, it's not got the most perfect predictive value in there, but it's the best out of what we've got. So I think it's, yeah, the SVC would probably be the most robust, but it's far from perfect. So I think one of the last things I'd like to then show you, if we're talking about echo to guide fluid management, is the importance of serial assessments. So a lot of what I've spoken about there is about fluid responsiveness and trying to predict fluid responsiveness. As I've probably given over my own personal biases, which I think it is not perfect, and that's where this importance of serial assessment comes in. And one of the particular things that I think is useful with serial assessment, as well as looking at the change in some of those parameters that we've just talked about, so whether there'd be a decrease in your, you know, your SVC collapsibility, or a decrease in your LVOT variation or something. One of the ones I'm using more and more these days is trying to get an idea of other hemodynamics, particularly looking at some of these markers of preload that we have from diastolic function. So here's an example of someone before and after a significant increase in their fluid status. And the importance that we can look at is, you see, before and after, we talk a lot about, when we talk about valvular function and we talk about diastology, about the preload dependence of markers. And they are all then absolutely fair game to try and tell you when you're starting to get on that flat portion of that Frank-Starling curve, when as you give fluid, you see these markers increase. So the example here in this before and after shot is the fact that the mitral regurg looks much worse after the increase in fluid here. So if you're seeing someone's MR get worse as you're giving fluid, that is a sign to stop giving fluid. The MR also assessed by continuous wave Doppler. You can see that the profile is now much more defined. You can see the whole parabolic curve, and the inside of that parabolic curve is denser after the fluid bolus. Again, an indication you've got more blood being injected with your mitral regurg. The E and the A ratio, as we know from talks on diastolic function and left atrial pressure, is preload dependent. So that means as you start seeing an increase in your E to A ratio, that can be a marker of rising left atrial pressure. And again, an indication that you are starting to increase your left atrial pressure and you should be looking to stop giving fluid therapy. Again, I should say that this is not hard and fast. You've got to put this into clinical context, but I'm just saying what I'm starting to do more and more. As well as that E to A ratio, you can look at the E wave velocity. If it's again starting to go up, we know that the E wave is preload dependent. The decel time can get shorter and shorter. So the decel time before was well over the 240 that we look at, whereas on the left we start to see it reduce down closer to the 160, which is where